Bismillahirrahmanirrahim. We are going to start the 10th session of this conference. This will be on stem cell transplantation in pediatrics. Abu Rish, Cairo University Center Experience. This center is actually guided and supervised by Professor Dr. Khalid Salama. Professor Dr. Khalid Salama is a pioneer now in stem cell transplantation. He's one of the students as well of Dr. Lucarelli, and he was a colleague with Dr. Petro Sudani. And this is a great honor really to have this experience with the most famous people in the world on stem cell transplantation in thalassemia. All of us know Bizarro classification, which comes out from Bizarro, where Dr. Lucarelli is there, and whereas Dr. Petro Sudani has been a student to Dr. Lucarelli. Now he is a big scientist in the stem cell transplantation all over the world. His name has always existed in any updated stem cell transplantation in thalassemia. I have the honor, great honor, to be with Dr. Khalid Salama, the director and the main professor of stem cell transplantation in Abu Rish Hospital of Cairo University. He's a pioneer. He's a great scientist in this domain now with his great team. Actually, he's very lucky. Most of his team are females. All of them are beautiful females as well. And you are going to see now the presentation and the outcome of his great success in stem cell transplantation. As well, I have my beautiful assistant professor, Dr. Rasha. Dr. Rasha is assistant professor in our department, which including hematology, pediatric hematology, and stem cell transplantation. One of our beautiful students in stem cell transplantation is Dr. Maryam Saad. Dr. Maryam Saad is going to present stem cell transplantation in thalassemia and other hereditary anemias. Please, Dr. Maryam.
So good afternoon, everybody. I am Maryam Saad, and I'm a lecturer of pediatrics at the Cairo University. Today we're going to talk about the hematopoietic stem cell transplantation in patients with thalassemia and other hereditary anemias. But before I start, I would like to thank Dr. Amel and Dr. Khalid for giving me this opportunity to stand up here and present my topic. I know we're at the end of very two fruitful days, and I promise I'll do my best just to make this concise and quick. So first of all, we'll talk about hereditary anemias. In short, there are many causes for hereditary anemias. They could be caused by increased destruction of the red cells, more commonly caused by thalassemia, sickle cell anemia, sideroblastic anemias, or hereditary anemias could be caused by the decreased production of red cells, more rare types like Fanconi anemia and diamond blackfin anemia. In our center, we've transplanted patients with thalassemia and patients with sideroblastic anemia. So these are the two types we're going to talk about today. A quick overview of beta thalassemia. It results from the absence or reduced synthesis of beta globin chains causing ineffective erythropoiesis. And in Egypt, there's a high carrier rate of beta thalassemia with 1,000 per 1.5 million new cases per year. Morbidities arise mainly from the iron overload, which occurs secondary to blood transfusions, and treatment of thalassemia is mainly supportive by regular blood transfusion, and when iron starts to accumulate, we start giving the patient iron chelation. Due to the better understanding of the pathophysiology of iron overload and to better modalities in the treatment, survival into the 4th or 5th decade of life is now made possible for well-treated patients. However, in countries with limited resources, like developing countries like ours, there are some challenges to the optimal care of patients with thalassemia. These include high costs. That in one study it was found that a single patient from his infancy till he reaches adulthood can cost more than $200,000 US. Lack of blood banking facilities, risk of bloodborne infections, namely HCV virus, Alloimmunization and other transfusion reactions that happen in patients who are frequently transfused, poor compliance of the patients to the transfusion and to the iron chelation, and poor quality of life for both patients and their families. These challenges all render the allogenic hematopoietic stem cell transplantation as the only available curative approach for thalassemia. And in fact, it should be proposed to every patient with transfusion-dependent thalassemia who has an HLA-matched donor before development of complications. There are some advantages of stem cell transplantation over transfusions. First of all, it has high cure rates, that in some studies it's been more than 90% survival rates, lower cost and better cost effectiveness on the long run, with a better impact on quality of life for both the patients and their families. There are many factors that determine the outcome of stem cell transplantation. Today we're going to be short and we'll discuss few of the patient factors and few of the donor factors. The patient status at the time of transplantation is the most critical element in predicting outcome. And as Dr. Amal just mentioned, in a study carried out in Italy, the biggest study that transplanted pediatric patients with thalassemia, they came up of the Pesaro classification, in which the patient with thalassemia is put into one of the three classes, depending on his hepatomegaly, whether he's got liver fibrosis or not, and his adherence to chelation. Patients with class 1, they have a better outcome than patients with class 3. Now, the donor type could be a matched sibling, and this has, again, a high cure rate with more than 90% survival rate. The donor could be a matched unrelated donor, and this is safe for young patients with class 1 and class 2, or a haploidentical donor, and as discussed yesterday, this has high rate of survival that is similar to the matched sibling and the matched unrelated donor. Again, hematopoietic stem cell transplantation is not a smooth process, and there are many challenges to it, especially in developing countries. Because the resources are so limited, the priority is always for the more urgent conditions, like patients with leukemias, patients with bone marrow failure, or patients with immune deficiencies. Affordability, because these countries, they have a low budget for the health system. Accessibility, it's not accessible for all patients because it's, again, present in urban big cities, and remote cities, they're not accessible to the stem cell transplantation. The age limitations, better prognosis is in younger patients. Donor availability, because we're talking about hereditary anemias, maybe one family can have more than one affected sibling, so donors may not always be available. And the program availability, stem cell centers, they're not available in all cities, and when not all centers are acquainted to different types of transplantations and different conditioning regimens. Gene therapy in beta thalassemia has recently been introduced, and it introduces a normal functional copy of a gene into a cell in which that gene is defective. It represents a subtype of hematopoietic stem cell transplantation. This diagram simplifies how gene therapy goes. First of all, we have a patient, we do a bone marrow harvest, and this collected CD34, they're being infected with a virus containing a functioning gene of the beta globin gene. Meanwhile, the patient receives a myeloablative conditioning regimen, and then we transfuse back the transduced stem cells, we transfuse them back to the patient, and we wait for the engraftment to occur. Gene therapy has a number of advantages over stem cell transplantation. As it's obvious, we do not need an HLA matched donor. And because we use autologous stem cells, there is no risk of graft versus host disease, or there is no risk for rejection. And we do not need to give the patient immune suppression following the gene therapy. There are few published phase 1 and 2 clinical trials showing promising results for the gene therapy in patients with thalassemia. Now we'll move on to sideroblastic anemia. It's a heterogeneous group of disorders characterized by ineffective erythropoiesis and increased total body iron. It's characterized by anemia of varying severity and the presence of ringed sideroblasts in the bone marrow. Treatment of sideroblastic anemia, some patients can respond to vitamin B6 and can make them non-transfusion dependent, and if they're responsive, they should continue on B6 for life. Some studies also found that folic acid on its own can reverse the sideroblastic changes in the bone marrow. However, if the patient is non-responding to the B6 therapy or the folic acid therapy, we are left with the supportive treatment, that is blood transfusions, and if the patient starts to accumulate iron, we give him chelation. But when do we do stem cell transplantation for a patient with sideroblastic anemia? It's reserved as the last resort in a patient who is resistant to pyridoxine, in a patient who is transfusion dependent, with an HLA matched donor. Well, to the best of my knowledge, there are few reported cases in the literature for patients with sideroblastic anemias who have done stem cell transplantation, and they've all have good outcome. The patient was engrafted at the end. However, Mederius and his colleagues in 2003, they tried a non-myeloablative conditioning regimen for the patient with sideroblastic anemia. The patient was engrafted, but unfortunately he died almost 6 months post-transplant. In our center, we've transplanted so far 21 patients, 19 of which had thalassemia, and 2 patients with sideroblastic anemias. 11 of our patients were males, and 10 of them were females, and their ages ranged from 3 years to 11 years. Patients of thalassemias, the one patient was in class 1, and the rest of them were class 2. We did not do any patients with class 3. We used a myeloablative conditioning regimen, BuSci ATG. 18 of our patients had HLA matched siblings, and 1 patient had a matched unrelated donor. The mean donor age was 9.3 years with a range between 2 and 18 years, and 2 of our patients had a bone marrow stem cell collection, and the rest of them we did a peripheral stem cell collection. The mean CD34 dose was 12.4 times 10 to the power 6 per kg, and TLC engraftment occurred after a mean of 22.5 days. 6 of our patients had acute GVHD, 1 patient had grade 1, 2 patients had grade 2, and 3 patients had grade 3 GVHD. 1 patient had a primary graft failure, and 4 patients had delayed engraftment. 2 of these patients, they received a booster dose of stem cells following ATG. 4 patients rejected. The overall survival was 13 patients out of 19, and the causes of mortality were attributed to overwhelming infections and some rare causes like macrophage activation syndrome, acute toxic myocarditis, and post-transplant lymphoproliferative disease. We transplanted 2 siblings with sideroblastic anemia, aged 6 years and 11 years. That we used again a myeloablative conditioning regimen, BuSci ATG. The donors were HLA matched siblings, aged 8 years and 10 years. We did a peripheral collection of the stem cells, and the CD34 count was 10 and 11 times 10 to the power 6 per kg per dose. TLC engraftment occurred at days 19 and days 21. Luckily, none of our patients with sideroblastic anemia had GVHD, graft failure, or graft rejection. Now this is a picture of my team, and I'm happy to end my talk with this picture. Thank you.
Thank you, Dr. Maryam, for this very nice talk.